off. Let's hop over to Facebook. There we go. And we are live. Let's go ahead and start the show. People are already waiting in the room. Love to see it. Let's not keep them waiting any longer. Hello, everyone. Welcome to Luncheon with the Experts, a Carcinoid Cancer Foundation and LACNet's program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this episode and every episode, and I am a filmmaker and a writer, among a few other things, by trade. And I have had the fortune to work with CCF for over 10 years now. I usually say for about 10 years, but the years keep going on. I can't stop it. So now it's about 12 years. And in that time, in that decade plus, we have created, I haven't kept count, but I would argue up to, I don't know, hundreds of videos, maybe 1,000 videos, different kinds of videos, live videos, Q&A sessions like the one you'll watch today, patient-centric documentaries, dense treatment-based videos, but all with one single mission in mind, and that is to spread awareness and education about neuroendocrine tumors. That is what we are here to do. Now, here at the show, Luncheon with the Experts, I think that the value you will receive is really twofold. Absolutely, the information and hopefully answers to your question from our guest today, but also the community, the shared stories, the shared experiences within the community, the overall net community, as well as the smaller concentric circle of this Luncheon with the Experts community. So, speaking to that point, you can see some people already saying hello in the comments. I urge you to do the same thing. Tell me where you're signing on from across the world. We'd love to see how far these stretch. Our guest today, whom I have not announced yet, already seems to have patience in the chat saying hello. So do the same. Embrace this community. I assure you, it will embrace you back. The power and strength of the net community is like nothing I've ever seen. It is really beautiful. Before we move forward, we always want to thank our sponsors, Ipsen Biopharmaceuticals, for their support, because quite honestly, we couldn't do the show without that support. And we do have this disclaimer from them at the top of the programs, and that is that the opinions expressed by the guest presenter today, as well as the questions asked by the audience that you all at home, haven't been created or suggested ahead of time by the sponsors of Luncheon with the Experts. And CCF and LACNets do not necessarily endorse or promote any of the views, opinions, or information provided in today's presentation. So this is the main takeaway. Audience members should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Okay, I always pick on disclaimers after I get done reading that because they tend to be a little bit wordy. But the point is that each case of this disease is unique. That's something that I have learned, even having a tangential role role in this community. And we don't know your specific case unless, our guest is your doctor, but most likely we don't know your specific case. So take the general answers and advice that we give you today, take that back to your home team, which does know your specific case. And then you can make the best plan and path forward for you, because that is one thing I have undoubtedly learned, that each plan and path forward is different for each unique case. Okay, enough alluding to the special guest today. I am excited to welcome to the show for the first time, Dr. David Zhen. Dr. Zhen, how are you?
I'm great. Thank you for having me.
Thank you for being here, especially from your home in the morning hours of the West Coast. I very much appreciate your time. Now, I've been talking about this net community. For those that might not know you or know your work, what do you do? Where do you work? And what's the role that you fill in this net community?
Yeah, so I am a GI medical oncologist here at the Fred Hutch Cancer Center and University of Washington here in Seattle. I've been here now for 7 years, and I think one of the things and my passions has been taking care of patients and also doing research, particularly clinical trials for patients with neuroendocrine tumors. We are still a fairly young program. However, we developed a program here at the Fred Hutch dedicated for neuroendocrine tumors, and that's been kind of excitement in terms of caring for this patient population. So
That's awesome. When did you start working on that program specifically?
Yeah, so I joined the institution 2017, and how I kind of got involved is, I became involved in developing national clinical trials, particularly through the National Cancer Institute, the NCI, and that kind of led a natural impetus and for us in recognizing that, before I came, our institution has taken care of a lot of patients with neuroendocrine tumors, but we realized that we really needed a central kind of forum to be able to discuss cases, manage cases, and
Yeah.
kind of unite everyone together. And so, along with my co-director, Dr. Delphine Chen, who many of you may know in the area, she's a very talented nuclear medicine expert. Two of us created a tumor board in 2018. And since then has just led to the development of a program. And so we're trying to expand upon our clinical program as well as our research program as well.
That's so awesome. Speaking of clinical trials, I do believe that we'll get plenty of questions about those today. So great that you have experience with that. What percentage would you say of your patient population are net patients?
Yeah. So I would say, obviously neuroendocrine tumors obviously can happen anywhere in the body. A large proportion of though will happen within the abdominal organs.
Mhm.
So what we term as gastroenteropancreatic neuroendocrine tumors, or GEP-NETs. And in that proportion, I would say, as a GI oncologist, we all see different cancers, although I really specialize heavily on neuroendocrine patients. And so for me, in terms of my practice, I would say 80 to 90% of my practice is
Oh,
purely
wow.
just neuroendocrine tumors. Yep.
Gotcha.
So,
Gotcha.
yeah.
Awesome. Well, folks, go ahead and start sending in your questions. Jim, Dr. Zen, your patient, says hello from your neck of
Yes.
the woods. Lots of Canada, lots of Washington, surprise, surprise, in the audience today so far. Lots of Canada. And folks, I am here in North Carolina. And very quickly, I don't want to make it about myself or my state, but I would be remiss if I didn't send a special shout out and some love to the folks of Western North Carolina, as well as Georgia and Florida, and that whole strip of people that are still without power dealing with the aftermath of Hurricane Helene. It's pretty crazy. I am in Durham, North Carolina, so luckily to the east of where that happened, but I grew up in Eastern North Carolina on the coast, so I'm very, very familiar with the pain and struggle and chaos that comes from the destruction from hurricanes. So all love to those impacted by that awful storm. Folks, go ahead and start sending in your questions. I see lots already pouring in, so that's exciting, and we will do our best to get to all of them. If we don't, two things: one, join us next time in just 2 weeks. That's kind of what keeps the show going. But also, you don't have to wait that long. Reach out to us with any follow-up questions that you have. One of the great things of the merger between CCF and LACNets that we've been able to provide is a support line. You can reach that at lacnets.org/support line. And that is for anyone affected by nets. So if you need to receive support, patients, caregivers, etc., can fill out a questionnaire there at the lacnets.org/support line and hopefully get the answers and get some direction for the struggles that you are having. When you send in your questions today, there is no limit. If I miss it, you're welcome to ask it again, or if we need any clarification, you can chime in. If you have a follow-up question, you can always ask that again. But I do ask from you to ask in small generic chunks. It's easier for us to field them in this manner versus a long list of all the specific details. If Dr. Zen needs a little bit more information from you, he'll ask, and we will do our best to get you that answer. Okay, so let's get into it because we already have a lot coming in. I missed one about Afinitor, but I've got Shane, who always has great questions every week. Shane says, with DAX, DAXX, and ATRX being common mutations amongst PNETs, do you know of any research going into targeting these ALT pathways? And if you don't mind, let's give a little bit of explanation of some of those things that he mentioned, if we can.
Yeah. So Shane, thank you for your question. So just for the whole community. So, when we think about neuroendocrine tumors in general, particularly coming from the abdomen, we generally divide neuroendocrine tumors as either coming from the pancreas and then kind of everything else. And the reason we do that is there is unique mutations that occur, particularly ones that come from the pancreas. And I think DAX and ATRX are probably the more common in that group of patients. And what DAX and ATRX, these are genes that lead to the production of basically proteins that ultimately are involved in managing the DNA. So basically the DNA is our blueprints for our cells. And mutations or changes in the DNA can lead to development of cancers, including like neuroendocrine tumors, right? And so these have been known for a long time, for many decades. We know these are very common gene mutations that we see in patients with neuroendocrine tumors, particularly those that come from the pancreas. And I think Shane's question is very relevant of, are there any potential treatments that are targeting these? And I think for that, obviously that has always been an area of interest. I think one of the challenges, which is very similar to many other different cancers, where there's mutations that we know that exist in cancers, developing specific molecules that can actually get to those or target specifically that leads to an effective cancer treatment can be very challenging. So the biology is very complicated. And then likewise, how do you also develop a treatment that doesn't necessarily lead to significant side effects, right? So I think there has been some research that have tried to do it. I think, that hasn't been all that successful. Now, with that said, I think there's a lot of other ongoing research, not necessarily on these, but kind of related things that are also kind of that are intertwined in terms of how DNA is repaired and everything. And so I think there's a lot of research that, while it's not directly at that, it's kind of targeting that same pathway towards the mutations. Yep.
Got it. Hey, thanks, Shane. Appreciate you as always. Thank you as well, Dr. Zhen. Next question from Anne coming in from YouTube, which is our community there is growing every episode. So that's exciting to see. Is there an alternative drug for Afinitor? And let's talk a little bit about what Afinitor is as well.
Yeah. So Afinitor is the brand name of an oral targeted agent, or some would also say chemo drug, called everolimus. So that's the other name that we also call it, and it's what we call an mTOR inhibitor. So mTOR is just one of these proteins that when cells grow, you kind of need an on and off switch for basically to tell a cell to grow, and an off switch to tell it to go to not. And mTOR is one of these things. It's kind of an on switch that can be relevant in neuroendocrine tumors and allow it to grow. So Afinitor or everolimus essentially targets this specific protein and tries to inhibit the development of cells. So I think I'm getting to the question in terms of that. Are there alternatives? I guess how I would kind of rephrase that question is there are other treatment options that are available as well. As we know, there's various different treatment options for neuroendocrine tumors. So there's not just everolimus, right? It depends on where your tumor comes from. So for pancreatic neuroendocrine tumors, certain other oral chemotherapy agents, for example, like capecitabine and temozolomide, or what we call CAPTEM, is also an effective treatment. There's other agents like sunitinib. These are other target agents. We have a new treatment that potentially will be FDA approved this coming spring called cabozantinib, which also targets in terms of the blood supply to the tumor and such like that. So I think to answer your question simply, yes, there are other treatment options available. I think one of the things that we have to think about, which I don't know all your history, is what prior treatments that you have in the past. And then likewise, one of the big areas of research in the field of trying to understand with all these menu of options is how do we sequence? In other words, how do we determine which treatment to start off versus wait till later? And that's an area of ongoing investigation.
Yeah, I mean, that's such a common issue that we discuss here. How do you approach that? And I know this is a big question, so bear with me. But in terms of
Yeah.
sequencing, um, what are the factors and variables that you even look at to think about that?
Yeah. So I think the first thing I always say is the way that we advance our care for patients with cancer, and more and very relevant for patients with neuroendocrine tumors, is that we need to finish our clinical trials, right? We need to participate in trials, and fortunately, there are multiple ongoing national trials that hopefully will answer these questions of sequencing in terms of how do we order the treatments, and does that impact outcomes for patients. Obviously, that's going to take many years, so we're not going to have those answers, right? So like you said, Rain, we have to make those decisions now, right? And then I think there's no perfect answer in how we do it, but I think there's a general consensus of number one is we think about the treatments themselves in terms of how effective they are. Again, without any data that one treatment is better than the other, we do know some treatments have differences in terms of, for example, the rates in terms of they might cause tumor shrinkage, right? So for example, if there's a patient who's having a lot of tumors and they're having a lot of symptoms related to that, I might need a treatment that affords me a little bit more shrinkage, right? In that case, then I might prefer that treatment over another treatment that doesn't provide as much shrinkage, because when I get that shrinkage of tumor, it allows the patients to feel better, right? Versus another patient who, let's say, might have smaller tumors, but they're
Mhm.
growing, but I don't need to worry that much about shrinkage. I just need to keep it stabilized. Then probably all the options are relevant, right? But I think even what's more important for me also is the quality of life for my patients, right? So each of the treatments have very different side effects. And so that's a discussion that I have with my patient of like, well, here are the different options if they're all fairly equivalent, but they differ in their side effects. Which side effects are we willing to
Yeah,
tolerate or not tolerate, right? So yeah.
absolutely. Absolutely. Great point there. Dorothy says or asks, with 80 to 90% of your patients being net patients, do you still consider this a rare cancer?
It's a great question, right? So uh, the definition of rare, I think we have to start with that, right?
Yes.
So based on the definition of rare, there's like a certain incidence that at the national level, particularly defined by the National Cancer Institute, is considered rare. And I'm blanking off on the number right now, but neuroendocrine tumors have always fallen under that category. I think that's going to change, right? Every few years or so, we have a new publication that's updating in terms of what's the incidence and prevalence of cancers, including neuroendocrine tumors. And I will say, I think we're seeing a lot more of this, right? Granted, I think some of us see more of neuroendocrine tumor patients than other places, right? But I do think overall, as a general, I think we're starting to see more often. Whether that's because we're doing more scans and we're catching these cancers more incidentally. Regardless, I think that we're seeing it much more often. That I think if we wait a little bit longer, if we just kind of look at the graphs over the trajectory over the years, the numbers are just rising, right? So I think at some point we're actually going to exceed those numbers when we do that analysis. That it's not going to be any rare cancers, right? So
Gotcha. Gotcha. Thanks, Dorothy. Appreciate your comment and question. From Denny. Denny says, can radiologists' standard work protocols be changed for net patients that need more information? Some of us have tumors too numerous to count, and seeing measurements for 2 or 3 target lesions will never provide enough information to evaluate progression versus stability.
yeah. So that's a fantastic question, Denny, and I think this comes to the challenges of when we do scans for patients with neuroendocrine tumors, right? There are so many subtleties in terms of reading scans, and what I mean by that is sometimes what we might see as changes meaning either specifically like growth, which is probably what patients care about the most in terms of is my cancer getting worse or not. Sometimes those changes are very, very mild, right? So and when we look at it, it's like it's not something significant. That's something that's not going to cause harm. And sometimes if we just watch it a little bit longer, things even stabilize. And so we don't want to act on too many of these things because then it leads us to sometimes initiating treatments when we might not need to initiate treatments. And I think getting to Denny's question is sometimes when there's the way that we read scans right now is that we sometimes just have to pick the most representative spots, right? So meaning sometimes the larger ones, and then we kind of use those to compare, right? But then he's correct that in some patients with many different tumors, there's way too many to encompass, and how do we do that, right? And I think there's two things to the standardization. Number one is to the point of how do we encapsulate every single type of cancer and that kind of thing, and that's where I think I'm very lucky to work with some very talented radiologists and nuclear medicine experts who can look at the scan. So that's why we have the tumor boards. That's why it's very important, right? Because in a report, if we were to list every single spot, that report would be almost 20 pages long, and that's just not practical, right? So I think what we end up doing is when we have those questions where we're not sure, we always bring our cases to the tumor board where we can sit down together and we can actually look at the scans, right? So even if we look at a couple spots, sometimes the radiologist gives me a viewpoint that I didn't realize, and they're like,
Mhm.
sure, there might be a couple of these, but if we look at 90% of all the cancers, it's pretty stable, right? So number one, I think that discussion is important. And then two, yes, I agree, there is a standardization that has to happen. And while there are some criteria that we can use to standardize things, there's a lot of things that we also don't know, right? So I think there's still a lot of work in the radiology community about what is a standard protocol. But I do agree we should get there, but I think there's still ongoing work to get there. So.
Gotcha. Gotcha. Thanks, Denny. Next question comes from Susan on behalf of her husband. My husband has metastatic net lung cancer and is asymptomatic since diagnosis 2017. On octreotide, just started everolimus. How long can this state of things continue, i.e., no symptoms? I know this is a lung net, but can you still kind of address her question?
Yeah,
Okay.
absolutely. And even though I am a GI medical oncologist and I mainly focus on neuroendocrine tumors from the GI tract, I do see some patients with neuroendocrine tumors of the lung. But
Yeah.
in our institution, our lung group actually sees a lot of them, and they're all part of our tumor boards, right? So
It's
we
like
end up
this
talking about
Venn
cases.
diagram, right? With like lung
Right.
cancer, nets, and
Yep.
then in between, and some institutions handle it in this camp and some handle it in that.
Yep, exactly. And I think to answer that question, I think that this is actually relevant not just for the lung. This is actually many patients with neuroendocrine tumors in general that you might just not have symptoms, right? So you don't have to have symptoms, and that's actually a positive, right? At least from the quality of life standpoint, right? And I think to answer your question, I think it's always very difficult to predict in terms of how long one might not have symptoms. But I would often say I think a couple of things to take into consideration is most, not all, most lung neuroendocrine tumors, and also many of the slow growing neuroendocrine tumors of the gut, because they're so slow growing. What I often tell my patients is your body has time to compensate for it, right? As opposed to, let's say, a very fast growing cancer where things just dramatically change and there's no way for your body to have time to take, right? So I think as long as the tumor is behaving in that fashion, in terms of being a slow, very slow growing process and stuff like that, oftentimes I'll notice in my patients that they won't develop symptoms. With that said, if it gets to a point where things get really advanced or something, sure, something might start happening, but it'll probably take a while before that happens.
Got it. Hey, thanks, Susan. Appreciate your question. Excuse me. From Catherine, can you share how many of your GI neuroendocrine patients with carcinoid syndrome go on to develop carcinoid heart disease? This is a great question. And
Yeah.
how do you see that unfold and treat it?
Yeah. That's a fantastic question because as much as we all think that we know about it, we actually are still actually learning. The numbers have varied in terms of what the incidence of carcinoid heart syndrome is. But I think there was actually a very interesting presentation that occurred this past month. So I was there as well. So this was presented at the European Society of Medical Oncology. So what we call ESMO, it's the equivalent of our American Society of Clinical Oncology, or ASCO. And they have annual meetings, and their annual meeting was held in Barcelona just a couple of weeks ago. And why I'm bringing that up is there were quite a few presentations on neuroendocrine tumors this year, and one of them was actually the carcinoid heart disease. So this was a very specifically focused research on patients with neuroendocrine tumors and trying to get some updated data about the incidence of carcinoid heart disease. And based on that most up-to-date publication, I would say it's around the area about 40% of patients might end up developing carcinoid heart disease, right? And what they were trying to get onto this paradigm is not understanding the incidence, but then, how do we monitor these things? I don't know if it purely answered in terms of how frequently we should be monitoring, but it did give us some insight in terms of the recognition that there are a good proportion of patients and that we need to talk about monitoring. I think at this point, in terms of how we monitor, I think number one, the first question is, does every patient who gets diagnosed with an neuroendocrine tumor need to get heart monitoring? I think that's an unanswered question. I think that the patients that we definitely need to do it are the ones who, let's say, have any sort of heart symptoms. So if we're doing a heart exam and we're hearing a murmur, which basically means it's the flow of the blood through a malfunctioned valve, then we definitely need to consider monitoring in those patients. Any patients with any heart symptoms like persistent shortness of breath or activity, right, swelling in the legs or stuff to suggest the circulation's not all that good, those are the patients that we need to start thinking about it, and then we need to do an ultrasound. And if we end up finding an ultrasound of the heart, and if we do find a heart abnormality, then yeah, we do need to do monitoring. And monitoring could be every several months or so, like 3 to 6 months or so. But that's where I get our cardiologists involved. So very early on. So if I'm already detecting that, I get our cardiologists involved, and they help with the frequency, determine the frequency of monitoring.
Got it. Thank you so much, Catherine, for your question. Um, And Anne asked if there's someone she can talk to about her case at the foundation. Yes, Anne, I mentioned at the top of the program, you can visit lacnets.org/support line. We'll try to put the link in the comments, but that is lacnets, LACNETS.org/support line. And absolutely, someone can talk to you further about your case and get you the answers you need, or to someone who can get you those answers. Folks, if you joined us a little bit late, this is Luncheon with the Experts. We are here today with Dr. David Zhen from the Fred Hutch Cancer Center at University of Washington, rather. I had mentioned at the beginning of the program some of the other programs that we do, video programs, one of which are patient-centric documentaries. I just wanted to give a quick announcement. We have one coming out in November. I'm hoping to release it for Net Cancer Day that we were just shooting last month in September. And speaking of Seattle, one of our best, I don't want to say best ones, but it did win some awards and get nominated for some awards, was back in 2018, called Fate and Friendship, about two friends in Gig Harbor, actually, close to Dr. Zhen there, who were best friends, lived in the same little town outside of Seattle, and both got diagnosed with NETs. So kind of a strange coincidence, but a really beautiful story with our friends Sochi and Ellen there. So check that out. That's one of our older ones, which is a really awesome story. Let's get on with the show. Back to the questions. Sasheen, our friend Sasheen, how are you today? Sasheen says, can sandostatin treatment cause lowered platelets with increased MPV? And if so, is this self-limiting or something to stay on top of?
Yeah, I would say so. Just to clarify, so Sandostatin is another name for the long-acting monthly octreotide that many patients with neuroendocrine tumors are treated with. So I'll start off by saying that a drop in platelets is not an anticipated or expected side effect that I would expect with Sandostatin. That's not to say it's impossible, but just with how the drug works and with the number of patients that I've treated, I haven't really seen that effect. So I would just make sure that there's nothing else that's going on with your doctor, just to make sure that all causes for why a drop in platelets that might be completely unrelated to your cancer whatsoever, right? So and an MPV, basically, this is a measurement that we see on the CBC, or the complete blood count, and an MPV just refers to the size of the red blood cells and stuff like that. So that in itself doesn't really signify a whole lot, right? But I do think that in terms of the drop in platelets, no, that's not something I normally expect to see with Sandostatin. So I would just make sure you work with your doctor to make sure there's not another cause for that. So.
Got it. Thank you. Next question from Jim. If you have patients with liver metastases who have had lanreotide injections for a few years, which lost efficacy, and then have PRRT, do you continue with lanreotide following the completion of the PRRT?
That's a fantastic question and remains an unanswered question in the field. So if you take 100 different NET experts, they're all going to give you a different answer. And the reason being is because we just don't have good data. So to address that question more specifically, so when I think about treating a neuroendocrine patient, the treatments I prescribe, no matter what treatments I give them, I have two goals in mind. One of them is either I want to stabilize or control the tumors. That's obviously one of the more important. But the second is also controlling symptoms, right? The symptoms could be related to the cancer, but also what I'm referring to more specifically is if the neuroendocrine tumors are making too many hormones, and those hormones are leading to symptoms, right? So carcinoid syndrome being the main thing that I'm referring to, the facial flushing, the diarrhea, and such like that. Okay. So the simple answer to that is, in a patient who has known, let's say, functional symptoms, meaning hormones are leading the symptoms, i.e. like carcinoid syndrome, it makes sense to continue the lanreotide after PRRT, because the goal there is I need to suppress the hormone production to make the quality of life better, right? That's very simple. I think where majority of patients fall are who don't have those hormonal symptoms or carcinoid syndrome. Do you continue to lanreotide? And why that's such controversy is you could argue two ways, right? Number one is you had been on lanreotide in the past, your tumors grew. And so the logical thing is if your tumors grow on the lanreotide, it means that develop resistance to lanreotide. So what's the point of continuing on with the lanreotide, right? That's how we think in oncology, right? However, with neuroendocrine tumors, oftentimes what we see is many patients have very slow growing tumors, and some tumors don't really grow at all. So there's always this kind of discussion of when they're really slow growing, maybe there's some groups of tumor cells that are still responding to the lanreotide. And because lanreotide is overall well tolerated treatment, why not continue on it with the hope that maybe there's still going to be some ongoing benefit, right? And there's some small studies that have suggested that maybe continuing the lanreotide beyond PRT is helpful, although they're not really designed in the way that fully answers that question. So that's why we're left in the field debating. And so in terms of my own practice, what I do, I often do just because I feel like, the treatment is overall pretty well tolerated. And if the tumors are really not growing that quickly, I do feel there may be some cells that are still responding. But the time that I stop it would be in the situation that somebody was on lanreotide, the cancers grew very quickly. I know it's not providing any benefit, so why give them a monthly injection anyway? Or my patients come back and say, I'm tired of the monthly injections, right? I just want to stop. So it would be very reasonable to consider that then. So.
Got it. Thank you, Jen, for that question. Next question from Patty. Hey, Patty. If another type of cancer occurs in a patient with NETs, such as breast cancer in my case, how do treatments affect each other or affect the tumors?
Yeah, so that's a great question, and this is not something that's just only for patients with neuroendocrine tumors. This is patients with any type of cancers.
Okay.
We often see cases where patients will develop a different, very different type of cancer, right? But specifically focusing, let's say, in neuroendocrine tumors, I think number one, the first question that always has to come up is in terms of which cancer is the most active, right? So we do have to treat both cancers, but sometimes one cancer is more active or going to be the driving force of the prognosis. So in that case, sometimes we might say, well, let's focus more on the treatments of that cancer that's actively growing. Okay. Now, when they're both actively growing, that's where it gets more challenging, right? And so sometimes the decisions, it's very complex, and so I can't necessarily answer it with one complete answer. It differs for each unique situation. But what I can say to that is, yeah, those are the considerations we have to take into account. So if both cancers are growing and they're both really active, then we start thinking about, are there treatments that we might have that could cover both cancers? That would be the best of both worlds, right? And so, for example, like in breast cancer, everolimus is an active treatment for breast cancer. Everolimus is a treatment for neuroendocrine tumors as well. That's not to say that's the recommended treatment for breast cancer for both cancers, but that's just an example, right? So I think we take into consideration, are there treatments that cover both? And yes, sometimes we might want to do different treatments for each of the cancers, but we can't because the side effects kind of interfere. So yeah, it requires a very, very complex discussion between the providers who's treating the neuroendocrine tumors, the provider who's treating the other cancers, and even getting a tumor boards involved, right, for both of those. So yeah.
Got it. Thanks for your question, Patty. Next question from Perry. Perry says, I've had a right adrenal removed in 2019. It went a year before cancer showed up in L1 and 2. Now a PET scan has found an adrenal metastasis in the left. What do you think is the best future treatment? By the way, I've already had 6 Lutathera treatments.
I think one of the things that I'll probably need to clarify is just what kind of neuroendocrine tumor that you have. So, is this a lung neuroendocrine tumor? Is this a GI neuroendocrine tumor? So I think that would be helpful in thinking about what different treatment options are going to exist for that. And then, again, I think part of it is, once with that information, I think I can give some options. Obviously, it's always a discussion. As I mentioned, there could be many different options where there has to be a discussion with your physician in terms of, what are the side effects, how's your health doing, and everything like that to think about what's the right choice. So.
Got it. Yeah. So Perry, if you are still there, feel free to chime back in with some of the information, or if you have any other questions. From Susan, can you use mycapssa? Is it mycapssa? In addition to octreotide infusion to treat carcinoid syndrome?
Yep. So just to educate everyone, because not everyone's familiar with mycapssa, but mycapssa is basically an oral formulation of octreotide. And this is actually approved as of now, right now, mainly for the treatment of another condition, what we call acromegaly. So acromegaly refers to a phenomenon that happens in patients where they're producing too much of one hormone called IGF-1, insulin growth factor 1. And that leads to basically the development of very long bones, which leads to long extremities, long arms, and long legs. And while it's great to have long extremities, it's actually not great when they get too long, because they actually get quite painful for patients and things don't grow properly. So this is treatments that's used to halt kind of the hormone levels and try to slow down that growth and stuff. So as of now, that treatment in itself hasn't been as well studied in neuroendocrine tumors. And so I think the two things that we worry about, as I mentioned, is you're trying to have tumor growth control, and you're also trying to control the symptoms, carcinoid syndrome, which I think was the question that was posed, right? So I don't know if we have as strong data about how well it works for carcinoid syndrome. Now, with that said, what I will say is there's another drug that's out there that's going to be investigated in clinical trials with very promising data, and we're going to be participating in those trials in the future. But it's a drug called paltusotine, which is another oral form, and there's actually some early signals from an early study demonstrating that as a drug that actually might be very helpful for patients in terms of getting their carcinoid syndrome under control. So more to come on that. So I think to answer your question, it's something I think, in terms of how the drug works, it could work. We just don't have great data about how effective it's going to be. So.
Got it. Hey, thanks, Susan. Appreciate your question. Next one comes from Amna. Amna says, "Hi, can lanreotide increase your HbA1c?" Kind of a
Yeah.
common question.
Yep. So lanreotide and octreotide fall under the class of drugs, what we call somatostatin analogs, right? So I'm bringing that up because somatostatin is basically the receptor that's on the surface of cancer cells, right? And that receptor is implicated in terms of the growth of neuroendocrine tumors, right? So lanreotide and octreotide, these are just drugs that bind to somatostatin receptors, right? I'm explaining all of that because somatoreceptors are not just on your neuroendocrine tumor cells, they're also on your normal cells, and they serve a normal purpose for you to make normal enzymes, particularly from your pancreas, right? So one of the side effects, long-term side effects that can happen with lanreotide and octreotide is that by the activation of this receptor on the normal cells, it can affect the normal function of normal cells, particularly in the pancreas. And so the two things that can happen when they affect this normal cell function on the pancreas is, number one is called pancreatic insufficiency, which means that your pancreas is normally responsible for making certain enzymes that help digest your food. So breaking down fats, breaking down proteins. So pancreatic insufficiency refers to you're not making those enzymes anymore. You're not absorbing the nutrients very well, and people can actually get diarrhea. And that's not due to carcinoid syndrome. That's actually just due to your pancreas not making the enzymes, right? But the other thing that can happen is also insulin resistance, and that leading to diabetes, right? So that's one of the things of the long-term side effects that can happen with both of these agents.
All right. Thanks, Amna. Hopefully that helped. Let me know if you have any follow-up questions. Question from Shane. 4-month follow-up scans post-liver debulking surgery showed a growth spurt in the remaining tumors. Deciding to stay the course with lanreotide, subsequent 4-month follow-up scans showed stability. Is this something that you see often?
Yep. Yeah, that's what we were talking about earlier about the imaging, and this is why it's very important to have a discussion with all parties that are involved, because there's many times, as I mentioned, sometimes you look at something and it's called growth, but the growth is very minimal. It's within even sometimes the margin and error of a scan, right? And so that's where sometimes when we're not really sure if this growth is real or not, and sometimes what we call growth, for example, especially with prior surgeries and such like that, is that you might have inflammation, right? So that might not even be tumor. That just might be healing inflammation from the surgery. So yeah, so sometimes when we're unsure, and as long as your health is okay and other things, very reasonable to observe and then see, right? Because sometimes if we overact, then we're initiating a treatment. And obviously, once we initiate a treatment, we want to keep all treatment options available, right? So we don't want to necessarily initiate treatment when we don't have to. So yeah, so definitely things that I've seen, and that's where I work with our radiologist to figure out, is this something that we can watch or do we think this is real.
You mentioned a moment ago the new drug that you all are studying. What was the name of it again? One more time.
You're referring to
No,
the
just
carcinoid
it was the
syndrome, or you're
previous
referring to
question. You were talking about the clinical trial.
the the
Um,
cabozantinib?
no, I thought it was something newer. Um, I think it was after the MyCapsa question. Am I making that up?
Oh, the yeah, I always
Pellucid.
butcher the
Got it.
name,
Got it.
pellucitine.
Well,
So yes,
either way, my question
yeah.
was going to be, um, there is a flurry of activity happening now, especially in terms of trials and things that are being looked at and developed, et cetera. If you could kind of write the script on where attention went, whether clinical trials or otherwise, in the next few years beyond what's happening currently, where would you like to see more time and effort
Yeah,
and money and resources spent?
yeah. I think number one, in terms of
Mhm.
just being practical for patients, is hopefully we can finish all our
For
long-standing
sure.
trials about sequencing, meaning that even though they're not like interesting looking at new drugs, these are the things that when I face a patient, I just don't know how to counsel because I just don't have the data, right? So I'm looking forward to investing in completing those trials so that finally I can have high level data that I can tell a patient, if I prescribe treatment X first, it's better than if I prescribe treatment Y first, right? So I think that's number one. Number two is always identifying new treatments, right? And I think it's very exciting that we have cabozantinib coming on board, but I think the next generation of drugs work very differently beyond just kind of most of the oral chemo drugs or targeted agents are kind of in one way or another blocking basically blood vessel
Mhm.
formation to the tumor, right? And while that's great, they also have their unique side effects. They have kind of temporary benefit, and so I think there's next generation drugs that work in very different ways. For example, some of what we call antibody drug conjugates, which basically the idea here is that there's a drug that recognizes a protein on the surface of the cell, and in this case, for example, somatostatin receptor in neuroendocrine tumors, right? But then what you can do with that is link that molecule to an active chemotherapy agent or something else that basically kills the cell, right? And so essentially, once they bind to the cell eats up the whole molecule and eats up the chemotherapy agent. And so basically, that's how you can target cells, right? Likewise, we're already doing that with radioligand therapy, which is PRT, right? And so there's the next generation of PRT, like
Mhm.
alpha emitter PRT as well. But then there's going to be novel targets, like how can we identify beyond the somatostatin receptor what are other things that we can target, right? So I think those are exciting things coming
Awesome.
down the
Awesome.
pipeline.
Appreciate that answer. Back to the questions from the audience from Sasheen. Early in the journey, pulmonic regurgitation increased from trace to moderate in 5 months with symptoms, no valve abnormalities. Can this be an early carcinoid heart disease sign? And how often should echoes be done? CHD is scarier to me than the NETs, honestly. Thank you both.
Yeah. Yeah, yeah. So I think one of the important things here is, I don't know the full
Mhm.
story of the situation, but I think I'm hoping that you have a good cardiologist that you're following with, because they're very specialized in terms of figuring out what the significance or how bad these are. So sometimes what sounds like a trace to moderate sounds really bad, but if you're not having any symptoms, it also means that that mild change that we're seeing on a imaging might not necessarily translate to something that means a worse outcome to your health. Now, if that's said, that doesn't mean that it's not something to be not concerned about. We definitely need to keep a close eye, but that's where the cardiologist helps to decide of like, is that severe enough that we got to increase the frequency of the echoes, and then is this a time that we need to get the surgeons, like a cardiothoracic surgeon, on board to have the discussion about when we need to plan for a potential replacement and those kind of things. So I think to answer your question is that I think it requires a lot of information, a lot of input together to figure out, is that severe or not? And then working with the cardiologist to figure out, does that change the frequency? But I would say, in a general answer, if it's something more significant, we do the echoes usually every 3 to 6 months or so. more frequently if we're worried about something's going to be changing. If we don't feel it's like significant change and you're feeling well, then we do it less frequently.
Got it.
So.
Thank you. And thanks, Sasheen, for your question. As always, from Catherine, I constantly have a low level of red blood cells that are always larger than normal and lose iron. How many gastrointestinal neuroendocrine tumors are hypervascular and leak blood into the digestive tract? How would you deal with this?
Yeah, so I think it kind of depends on each situation, but I would say small intestinal neuroendocrine tumors, or even neuroendocrine tumors that arise in the colon as well too. We often see it. Basically, the crux of your question is, can GI bleeding actually happen in patients with neuroendocrine tumors? That's an absolute yes, right? If we just think about it logically, if you got a tumor that's within the pipe, right, and it's destroying the pipe, right, that leads to tissue injury and everything like that. Sure, that's going to lead to some blood loss, right? Without knowing all of the informations of your case, right, sometimes that could be a very mild loss, meaning that even though the level's low, it's a very, very mild low and it's not causing any symptoms or anything like that. And that's something we just might monitor, right? To the other extreme, where it could mean really, really severe blood loss, where the blood levels are super, super low, it's making you really fatigued and not doing well. And that's a whole different situation, right? And I bring that up because it's common that we see it, right? But if it's a very mild drop and my patients are coming to me and that's the only thing we're seeing on the blood test, but they're saying, you know what, I'm not noticing any frank bleeding, I'm not having any pain, I'm not having problems. Oftentimes we just might monitor that. Now, if it's, let's say, a locally advanced cancer, we try to cut it out, and that might be helpful. Many of the times, if there's already too many tumors or something like that, that might not be the most feasible thing to do. So I think it all depends on the situation and such like that. So I think how we manage it really depends on how bad the bleeding is, where the tumor is, can we intervene upon it. But in the meantime, in terms of managing that, oftentimes we replace the iron, right? So if the iron levels are getting low, we either do iron pills or we also have IV iron formulations to get the blood levels back.
Got it.
So.
Hey, thanks, Catherine. Effie says, hello, it's been a while. Glad I made it on today. I am glad you did too, Effie. Appreciate you being here. From Denny, is paltusotine, is that right? Paltusotine
Yeah.
designed to be used with lanreotide, octreotide, or as a replacement?
Yeah, great question. As of now, I think the trials are going to be designed as a replacement to potentially lanreotide, octreotide. So it's going to be kind of the next generation drug, right? And what the convenience of this is being an oral drug, right? So no more injections, right?
Yes,
That would
I'm
be the hope.
sure.
So.
I'm sure people would appreciate that. We get questions about that quite often. From Eltaz, after 4 cycles of PRRT, can I request my oncologist to increase the interval of lanreotide injection from every 21 days to 28 days instead?
Yeah, I think the way I'm going to answer that question is, I mean, simply yes, you can definitely do that. It's safe to do that, and there's data that you can do that, especially. But I think the bigger question is, uh, what's the underlying reason that you have to do that, right? So if it's more for controlling hormonal symptoms, like you're noticing that the symptoms are coming back before your 4-week injection, that's probably the main reason why I go to every 21 days, is to help control that. If you're hoping that it will help with further tumor control, I think that's a much more controversial aspect, is whether that going to 3-week injections means much more better tumor control. So.
Got it. Thank you. Thank you. From Anne, is there an alternative to octreotide? I have an allergic reaction to it, large itchy bumps that last about 10 days.
Yeah, that is also a fairly uncommon side effect, not something that I see often. With that said, as much as we always say lanreotide and octreotide are the most well-tolerated drugs, I always have a very small percentage of patients who just seem to have very weird reactions to it. I don't know why. And so I think, what we do with that is, again, not something that's common, but if there's ways to try to mitigate that, for example, using medications like antihistamines or something, and that seems to work for you, and you can continue on the drug, that's great. If it's just not feasible and it's causing severe allergies, then we might have to consider
Got
alternative
it.
agents.
Thanks, Ann. Appreciate you being here. Folks, we have just about 10 minutes left, so go ahead and start sending in those questions now. If you've been nervous, if you've been waiting and hesitating, don't wait till there's 1 minute left in the show. Go ahead and send it now. And by the way, a lot of the things that Dr. Zhen has referred to today, trials, etc., drugs, anything like that, we have added, LACNET is added there in the comment section, so you can easily follow up on that, go down that rabbit hole, learn a little bit more instead of having to remember it or type it up. You can just click the links that we provide and it will take you right to more information for that. Blaine says, now 2.6 by 2.0 centimeter pnet. No, sorry. Now it is 1.8 by 1.4. Symptoms for 14 months that are not usually net symptoms. The question is, should I still consider surgery?
Yeah, I'm assuming based on how that question's phrased is that that's the only spot, right,
Mhm.
of cancer that's there. So, and I think this is referring to a situation that we often see of I'm going to also assume this is a low grade, meaning a slow growing type of neuroendocrine tumor, and it's just a tumor in the pancreas, right? And I'm also going to make another assumption based on how the question's worded that it's in the pancreatic head, meaning that it's in the front portion of the pancreas, which means in order to remove it, the type of surgery that would need to be done would be a Whipple surgery, which would be a very big surgery, removing not only the pancreas, but rewiring the stomach and the small intestine, right? So I think this is where it gets into the field of when you have a slow growing neuroendocrine tumor, which means it's probably not going to change for a while, and considering against the risks, long-term risk of what might be entailed in terms of a big surgery like a Whipple's, there's many situations for a pancreatic neuroendocrine tumor that we might just watch it for a period of time, right? But then the question always comes down to when do we consider a surgery? And I think there's a lot of aspects that we take into that. I think if the tumor is actually continuing to grow, I think we know that that's a risk factor, potentially that it might have a higher risk of spreading. So we'll probably want to do a surgery earlier. The size also does matter. So if the size gets particularly above 2 centimeters, I'm not saying that's an absolute cutoff, but that's kind of a general thing that many surgeons use, then we might end up talking about doing a surgery rather than later. But I'm glad to hear that the neuroendocrine tumor is actually shrunk in size. So, sometimes neuroendocrine tumors can act in funny ways, and I'm glad that it's not heading in the other direction. So I think if that's the situation, and you're not having symptoms, I think it's also reasonable to watch for a little bit longer. So.
Got it. Hey, thanks, Blaine. And listen, anytime there's something like that where Dr. Zen has to make an assumption, always feel free to clarify, jump in, follow up on that question. If you have other pertinent information that can help him get you to your more desired specific answer, please let us know. Moving along, Megan says, how unusual is it for primary tumor in the ileum to have a Ki-67 of 2% and mesentery lymph node metastases to have Ki-67 ranging from 35 to 60%, yet still well differentiated?
Yeah. So this comes into what we say about neuroendocrine tumors is that it can be very heterogeneous, meaning that not all tumors within a patient are going to behave the same. Okay. So it's not common, but not to say that it's unusual, but we have seen cases where the primary tumor itself started out as a very slow growing tumor, but as the cancer cells that escaped and are spreading can evolve and become a more aggressive process, right? So that Ki-67 is referring to the lower number was a slow growing process, and now it's becoming a fast growing process. So what I'll say to that does happen, right? That has implications about the treatment and everything like that. And can it still be well differentiated? So that gets to the question of, yes, the Ki-67 is on the higher end, but in terms of how we classify neuroendocrine tumors from the GI tract, we do have a well-differentiated, what we call grade 3, meaning that it still can be a semi-better behaving tumor, but it's growing a little bit faster, and that's referring to that higher Ki-67. So yes, that can happen.
Got it. Thanks, Megan. Next question from Susan. 3 years ago during COVID, I was passing blood daily, even without bowel movement, but never diarrhea. Went to GI in Atlanta, and at first he diagnosed as UC, ulcerative colitis. Then after some blood work and treatment, he thought it was not UC, but COVID. I moved to Oregon, saw GI. I've been on Humira for 2 years now. It controls the bleeding, but I have diarrhea almost daily. I was diagnosed with the pancreatic net a few months ago. The question is, how do I know if the diarrhea is from UC or from the PNET?
Yeah, I think with this, there's probably going to be a lot more information that I don't
Mhm.
know. But what I'm going to say in general is that you can have different medical conditions that lead to different symptoms. It's not always related to the cancer, right? That's very common in neurocrine patients, and so I think here, without knowing any other data about if there's any spread of the pancreatic neurocrine tumor, like other masses within the bowels or anything like that, it is absolutely possible that the diarrhea may just be from ulcerative colitis, because that can be from that. The only time that I might think that it could be from the neurocrine tumor would be if there's spread of the neurocrine tumor to the bowels or something that's leading to bleeding, right? But I think it's very, very possible that the bleeding is just purely from the ulcerative colitis if it's really just a mass and not doing anything to the bowels itself. So.
Got it. Thank you. And Blaine with the PNET previously did chime back in, said my PNET is in the body, grade 1, well differentiated.
Okay.
That was, you recall that question,
Yeah,
right?
yeah, and I think that the answer I gave still applies, yep, to that.
Great.
So
Awesome. Thank you for that. And thank you too, Blaine. Dun, dun, dun. We've got time for, 5 minutes. We've got time for just a couple more. Josh says, I had just had short acting octreotide and took 2 shots and got severe bloating and pain, and my stools afterwards were just pure grease. Any thoughts? Any guidance?
yeah, yep, I feel you. I actually have a few patients who are in that boat. Like I said, it's not a common phenomenon that happens, but I have some patients that, and again, I think it's likely due to the fact that it's inhibiting the normal function of the normal pancreas cells, which this is very similar to like a pancreatic insufficiency picture, right? And in those situations, if it was very severe, right? I try to give it one final shot, meaning if it was like octreotide that happened, even though it's the same class of drugs, I might switch to lanreotide to see if it makes a difference. If both are really difficult and they just can't tolerate it, then I might have to move on to different treatments in that situation, assuming the tumor is actually growing and I need tumor control, right? So, yeah.
Got it. Thank you. From Lisa, I've been receiving Sandostatin injections for 6 years. Recently changed to lanreotide. Received my first injection last month, and it was not so good. Had severe pain in an 8-inch diameter around area, which started an hour after injection, lasted 12 hours. Is this normal? By the way, there was no swelling or heat, just pain.
Yeah, this goes back to the very last question that Josh just asked, and again, same thing. I can't explain why, right? But patients do tolerate sometimes just the drugs differently, right? So as much as that, even though Sandostatin and lanreotide are the same class of agents, I have seen tolerance issues between the two drugs. So it just might mean that you just don't tolerate the lanreotide as well. So.
From Kat, is there research to better understand if NET cancer is genetic? Should family members be alerted to focus on testing, for an example, colonoscopy, to be aware that there may be risks? This is a common question we get.
Yeah. Yeah. So to answer your question is yes, there are some neuroendocrine tumors that can be hereditary, right? Most of what's well described in terms of hereditary are those tumors that originate from the pancreas, right? So there's several different genetic syndromes, for example, like MEN1 syndrome, von Hippel-Lindau, tuberous sclerosis, and others. And they're well described that they typically cause a higher risk of developing pancreatic neuroendocrine tumors, right? In terms of other neuroendocrine tumors within the GI tract, it's not as well described. I can tell you, though, there's been some very interesting research now from genetic counselors as we try to pull all our neuroendocrine patients together to basically identify, even if it's not well described, are there any familial factors that can contribute to other GI neuroendocrine tumors? And the answer is there have been described mutations where we see in these patients. The question always is, when we see those mutations, are those the mutations that led to the development of an neuroendocrine tumor? That's not well as known. And why that's important is because if we don't really know, how do we develop screening guidelines, right? What I will say is the NIH is very focused on this, and they actually have a whole registry now that they're planning to try to better understand the other mutations beyond those that are seen in the pancreas. So.
Thank you. Thank you. From Kari, will all metastatic GNET patients eventually develop carcinoid syndrome?
No. So we know that a good probably 40 to 50% of patients will actually have carcinoid syndrome or any sort of functional. So functional meaning not only do I test your blood and there's a hormone being produced, but that hormone's leading to a symptom, right? That's the definition of a functional. And so 40 to 50% will be functional, but the vast majority, in other words, the flip side of saying that is 50 to 60% of patients will not have functional symptoms. So
All right. I think we have just time for one more. Micah. My husband has a PNET, Ki67, 4%, PNET of 7 centimeters in the tail of the pancreas, METs in the liver, every segment, and a couple of bones. He just finished PRT. First scan shows stability. I see a lot of U.S. patients have debulking surgery. However, our European NET specialist is less supportive of that surgery. What are your ideas about debulking?
yeah, so it's a very loaded question, but I'll try to answer
Sure.
in 1 minute, which is that, debulking surgeries is an important treatment in neuroendocrine tumor patients, right? And the reason being is even if we can't get rid of all the tumors, there's some data suggesting that potentially it might increase the lifespan of patients when we do it. However, with that said, we actually have to select the right patients, right? So in other words, if the tumors are still growing, we can debulk most of the cancers and stuff like that. That's where we see the benefit. I think without knowing all the full details here, I think that the challenges here would be because there's spread to other parts of the body, for example, like the bones and stuff like that. The issue is that we're probably not going to be able to optimally debulk all the tumors. And so the question is, for example, like the ones in the bones. And so is that going to translate to a better outcome if we can't deal with those, right? And then there's the risk of the surgery itself we have to consider. So
Got it. That was pretty good for 60 seconds for a very big topic. Sean says, thank you, Dr. Zhen, for coming on the show and to help inform us these programs. We so appreciate this. And I appreciate it too, Dr. Zhen. Thank you for being here.
my pleasure. It's been an honor, and thank you for having me. So.
Absolutely. And thanks to you all at home. As always, we hope this program helped answer some of your questions. Again, I'll reiterate, you can always send a message to lacnets.org/support line if you need further guidance, advice, help. Thanks again to our presenting sponsor, Ipsen Biopharmaceuticals. We couldn't do the show without them. And finally, my name is Rain Bennett. I have been your host. Thank you for watching.